Thanks a lot to everyone. So I have some questions because we are all working in liver transplantation centers, and so we have to recenter the debate for those that are working in ICU, in general ICU, in fact, and that are receiving cirrhotic patients and that are asking themselves if they should transplant those patients. And so my first question is very practical for those intensivists. They are receiving a cirrhotic patients for a first or a second episode of ACLF. Should they call a transplantation center? If yes, when? What is your... that's a question I am frequently asked, and I would like to have your opinion on this because it's difficult. So,
I raise the hand. It's difficult, but not so difficult, in my opinion. The idea is that they should refer the majority of these patients to referral centers performing liver transplantation. Obviously, if this patient is a heavy alcohol consumer that has a very, very relevant dependency, or he has other contraindications, comorbidities, or elderly, or psychiatric problems, relevant psychiatric problems. In this case, no. But in the rest, in my opinion, they should refer the patient to centers with expertise, and we will decide.
Is it the same for everybody? I mean, we have a limited number of beds in our ICUs, so there are a lot of cirrhotic patients. Can we select them? I mean, should they call first and then we make our selection? Thierry, I want.
Yeah. My point of view is a two-step procedure. In my practice, I suggest you have a call before, because when you combine everything, the age, the comorbidities, something like that, you can limit the transfer of patient that you will exclude finally, and then it gives hope to the family and so on, and then it's a pity to perform like this. Then the first step is this, but in my point of view, if there is a window to perform a liver transplantation, we must transplant this patient very soon, because when you see the prognosis of patient based on the grade of ACLF between grade 3 to 7, you see that the patient with grade 2 or 3, the vast majority of the patient will die during the month. Whatever you perform a treatment or a management, the patient will die. And then when you look with patient with, for example, grade 1, you see that the prognosis at long term is not so good. Then I think this patient must be referred in a liver transplant center for a short term or for a medium term or long term. It's very important. And finally, also, at this time, we have no specific treatment for the ACLF syndrome. And then we must assess new treatment. And then we have no trial, assess some device or some cells to improve the survival. It's experimental, but this is the only way that we have to improve the prognosis of this type of patient. And then I stimulate the physician to call a transplant center for this.
I completely agree with Thierry. This is what we do. We do not accept any patient without a prior communication with us.
So they made the job, like they try to take care of the patient and try to stabilize and improve him, and then they transfer. I think we can all agree with that, no?
Yeah.
I am seeing Claire that is.
I agree.
Okay, and Javier, you mentioned the problem of alcohol that is also frequently mentioned when we have the calls. But on the other hand, we had previous studies on alcoholic hepatitis. So, what is your opinion on this problem? It depends from the also from the countries. So.
Right now, it is depending on the countries and on the centers. My personal view is that it should be individualized. These patients are exceptional. They should have a psychiatric, psychological assessment. You can perform, you can. We are going to do this in the clinic, for example. Yes, we have just opened this possibility, but we should confirm the French and Belgian results.
But it's difficult to evaluate them when they are when they get intubated. So I think we can say that if they get intubated and that's their first episode and they still consume alcohol, it's not recommended. No. If we can't evaluate them, because sometimes you can't just evaluate it.
Yeah, Manu, but you can evaluate the family. You can evaluate all what is surrounding the patient.
Okay. So that was the aim of my comment. Yeah. So in this case, you evaluate the.
Yeah.
Yes, Claire.
Yes, I would like to add something, because a lot of us think that young people with severe alcoholic hepatitis should have an access. Not of us, but the community think that young people with severe alcoholic hepatitis should receive a graft and should be evaluated for liver transplantation. And in our experience, and I know that it's the same for other centers, we know that young people below 30 or 35 are poor candidates for liver transplantation because they have a very severe psychiatric disease, underlying severe psychiatric disease, and the experience is poor with many patients who have a recurrence of alcoholic disease after liver transplantation. So the tendency is for young hepatologists or intensivists to say, yes, we have to transplant him because he is young. And we have to be cautious with that because these patients frequently have severe disease.
Thanks. That's true, and that's make the link with my my other question. It's about the previous history of the patient. This is something we spoke about we are intensivists, so we spoke about the organ failure. We spoke about alcohol, of course. But what about the age and I saw the picture of Claire, so showing different kind of patients, meaning the differences in terms of frailty. Should we? Is it possible to contraindicate somebody on this basis? Difficult question. Okay, so this is a multi-level problem that should take in.
It again, Manu, depends on the center.
Yeah.
I cannot transplant a patient with who is 71. I can't because of the rules. I can't. Maybe here, yes, or if you go to Rochester, they can. Frailty is again. I would not transplant a patient with a frailty score over 6. This is an error to me. But if you can pay, and there are some centers that in private medicine or something similar do, but in general, frailty should prevent liver transplantation. And age is not the same biological age than real age. No, the real or the standard age. You should evaluate. You should consider biological age. Some people aging 60 are seems to have 80, and the opposite.
Thanks a lot. Maybe one question for Richard. 10 years after, what is your opinion on the impact of this ACLF grade, and do you think what would you change, in fact, 10 years after?
It's a big question. For sure, we should improve our classification of organ failure. It was not so bad for classifying organ failure, but now we can adjust according to for each organ system, which is the best threshold, you know, and based on the hazard ratio for death, and we are working on that. The other point, for example, is regarding kidney failure. It is too simple. Based on creatinine above 2 milligrams per DIL, we should take into account the acute the deterioration of kidney function. Maybe by including AKI criteria, we have to work on this. Therefore, we have to improve our assessment of the 6 major organ system, and maybe we should also take into account in the assessment of the overall severity into account the frailty, the nutritional status, etc. And this is a way for improvement of the assessment. And also, we should improve, I think, but it is at the level of doctors. I was extremely struck by the results of the recent large national study during the pandemic, clearly showing that patients with cirrhosis, critically ill patients with cirrhosis and COVID-19, were underserved as compared with the other patients, at least in France. And therefore, we have to work to convince people in charge of the CUs that these patients merit to be resuscitated very actively. And we should put forward the evidence showing that the course of these patients has been improved by recent progress in the management of patients in ICU. These are the two comments I can make today. And another comment could be, I don't want to be too long, but recently we performed a large observational study in South America, a study called ACLARA, and we learned a lot about the socio-economical educational factors which may drive, I would say, the access of people to the health system. And we have to work, at least in Europe, to elucidate, I would say, the trajectory of the patient before they come to the hospital, to probably to improve and to reduce the delay of admission of patients who are severely ill.
Thanks a lot. I fully agree, and it makes that's a good conclusion for this session, because liver transplantation can provide we can provide to every intensivist an aim, saying that we can save those patients with liver transplantation, and if you can rehabilitate those patients in order that to give them the opportunity to undergo liver transplantation, maybe you can admit in your ICU a lot of those patients in this objective. So thanks a lot to all of you for being there this afternoon, this Saturday afternoon. It was a great pleasure to have this discussion with you. Hope to see you soon, and take care. Bye-bye.
Bye.
See you.
Bye.